Dear colleagues, welcome everybody to our new webinar of the ESGE after the summer break. This webinar is called Tips and Tricks for Successful Cannulation in ERCP. This is a very important topic. My name is Marcus Hollenbach from the University of Heidelberg, and it is my pleasure to have this webinar with two very well-known experts in ERCP, Professor Pierre Deprez from Brussels and Professor Enrique Perez-Cuadrado Robles from Paris in France. And I would please all the participants to use the Q&A button on the bottom of the Zoom link. And if you have any questions, just put it in. I will try to answer very simple questions directly, and the other one I will collect for an intensive discussion at the end of the webinar. And now it's my pleasure to hand over to Pierre Deprez for the first part of this webinar.
Good evening. It's a real pleasure for me. Thank you, Marcus, to be part of this webinar. I think it's indeed is a very important webinar. And in fact, my lecture will introduce Enrique lecturer, who will give you some videos and some tips and tricks. And I would like to share with you my concerns on the practice of ERCP, mainly as not only performing ERCPs, but also as an expert in court and dealing with patients with severe complications, patients who die, and patients who are getting into lawsuits. So I wanted to give you some slides and some information about how to assess the patient before the procedures in terms of adverse events and prevention, informed consent, indications, pre-ERCP assessment, prophylaxis for infection, PEP, anticoagulants. And then I will have just one slide with practical tips that will introduce the lecture from Enrique. So this year I was asked as an expert for 3 cases where patient died from ERCP performed by not beginners, but experienced endoscopists. And you see that it is still a problem in Belgium. It is still a problem, I think, in several countries. And you see there are not so many papers on this in the literature. And you see a paper by the famous Peter Cotton 13 years ago about 20 more ERCP lawsuits. Why? Mainly poor indications and communications. It may be not completely the same, but because I think the indications are now better defined, but we still have the problem, although there are several guidelines showing us how we have to proceed with an excellent ERCP with the lower adverse event rates. So we know that the range and incidence of adverse events related to ERCP differ substantially from those of other endoscopic procedures. And that the familiarity with these adverse events is critical to provide patient information during the consent phase, as well as prophylaxis for these complications and managements. And you see the rate of complications, about up to 10% pancreatitis, 3% cholangitis, cholecystitis, 1% bleeding, and well, less than 0.5% perforations. And you have also all the sedation adverse events. And we know the risk factors. So this is, I think, very important to keep in mind, because many often when I'm called as an expert, those risk factors, they have not been properly assessed before starting ERCP. And they are the risk factors for PEP, for post-ERCP pancreatitis, of course, suspected SOD, female sex, previous pancreatitis, previous PEP, but also younger age, non-dilated extrahepatic bile ducts, absence of chronic pancreatitis, end-stage renal disease. Always be very careful with these patients. They are in the bottom line of the list, but they are the most critical patients where you have to be very cautious and provide all preventive measures that are now available. The risk for bleedings are well known, anticoagulants and platelets, again, end-stage renal disease and cirrhosis, of course, and then the risk factors for cholangitis mainly hilar obstruction, previous history of ERCP, performing cholangioscopy, for example. So this is well known. So you should always be careful in these patients and do whatever you can to avoid this. Next step is communication. You have to communicate. All the files, all the suits, there was no proof of appropriate communication with the patient. And I think this is very important. It's based on human rights for autonomy and self-determination. It's not only for ethical aspects, but also for legal requirements in case of lawsuits. And appropriate informed consent procedures must include information about the mechanism of action, balance between benefits and risk, and the alternative treatments. And moreover, presentation must be as clear as possible in order to result first in the patient's understanding what the procedure will involve, and also about him or her agreeing or declining ERCP. So informed consent should be a dynamic process, and this was re-emphasized in the recent ESE guidelines on ERCP-related adverse events. And the patient must be given the possibility and the time to change his mind and to withdraw consent. Of course, we have not to scare the patients, because if there is no alternative, this should also be, this information should also be given to the patients. Also, I think a new paradigm is the information about not only ERCP, but also the alternative procedures, such as EUS guided drainage and agreement to perform either technique. It would be sad on this, at this time, to have to wake the patient up and to reschedule the patient for EUS guided drainage, although this option was available due to the accessory devices available and the expertise of the physician. So I think it's not acceptable to reschedule, because this had not been discussed with the patient before starting the drainage procedure. Now, going into the indications, I think the main problem is that ERCP is not anymore a diagnostic tool. So when I have a patient in a lawsuit because he had an ERCP and there was no stone and there was no EUS and there was no ERCP and there was no typical sign of or need for ERCP, that would be a real problem in a lawsuit. So you know all the indications, biliary lithiasis, of course, obstructive jaundice, and all the other need for stents or imaging of the bile duct and treatment. So pre-ERCP assessment should take care of knowing the age of the patient, the sex, obesity. Be careful, of course, with obese patients, altered anatomy. It would be sad to perforate because you would not be aware that the patient had a bypass and you just pushed the duodenoscope across the jejunum. So always be aware of this. This is not always mentioned in the patient file. You have sometimes to ask the questions directly to the patient. And of course, presence of cirrhosis, dialysis, steroid intake, increase of perforation risk, anticoagulants, allergy to NSAIDs, because you should give NSAID before starting ERCP. And you should be aware of the real contraindications, not the relative contraindications, but the real contraindications for NSAIDs. And of course, the infection status where maybe you should consider using single-use scopes. Pre-ERCP testing means blood testing, inflammatory parameters, of course, LFTs, bilirubin lipase, platelet counts, renal function, although ESG doesn't suggest to test coagulation on patients who are not on anticoagulants, who are not jaundiced. When we are dealing with stones, ultrasonography should of course be performed before performing ERCP. And when we go for patients with malignancy, I think CT or MRI or EUS or a combination of these three exams should give you some information about the stricture type, the site, and already a discussion, pre-ERCP discussion on the use of plastic or metal stenting. Same for pancreatitis. You should know if it's acute or chronic pancreatitis, if there are stone, if you have a huge stone in the head of the pancreas, of course, you should consider ESWL before starting ERCP. And also knowledge on pancreas divisum, very important. It's amazing that I still see complications because there were biliary attempts cannulation through the minor papilla with pre-cuts and sometimes perforation, although patients were not aware of pancreas divisum and sometimes of a protruding minor papilla. So if we go for a practical case, it's a case for common bile duct stones. If you have a symptomatic gallstone disease, you should at least have FLTs and ultrasound. If you have on the left side of the panel here, low likelihood of common bile duct stones, meaning normal test and normal ultrasonography, while only cholecystectomy should be performed. If you have a high likelihood of common bile duct stones with features of cholangitis or common bile duct stones identified by ultrasonography, of course, you go for ERCP. And in the intermediate cases, well, and I think this is advised by the ESG guidelines, you should perform EUS or MRCP to confirm presence of stones before starting ERCP. And if it's negative for common bile duct stones, you should go to cholecystectomy without performing ERCP. Some easy questions. Antibiotics, well, in the absence of specific risk factors for sepsis, such as sclerosing cholangitis, cyst, hilar strictures, liver transplant, cholangioscopy, or failed attempt to drain an opacified bile duct, prophylactic antibiotics can be safely avoided. And this is written in the ESG guidelines, but also in the UK guidelines. Prophylaxis for PEP. Well, this is very often the debate during lawsuits. The 3 patients who died this year in lawsuits in Belgium, they had no rectal administration of NSAIDs, either because it was forgotten or it was felt unnecessary. And there were, however, risk factors, obese patients or renal insufficiency, or not renal insufficiency, because that's a contraindication for NSAIDs, but there were other risk factors of previous PEP or young patients. And or the administration was not given because it was thought that there was a contraindication, although the contraindications for NSAIDs administrations are not so large. You have the allergy, you have the renal insufficiency, but otherwise most of the patients they can benefit from this. And if you do not administrate NSAIDs, well, you should go for lactate ringer or maybe a pancreatic stenting in patients with a high risk of PEP. So always be aware of this. Be very careful when you don't administrate NSAIDs. You have to get a good reason for this. For anticoagulants, I'm not going into the details because there are several guidelines that are describing the timing for stopping warfarin or the direct anticoagulants, and this is described in the literature, but also be careful. So patients may be on your list and that they forgot to stop the direct anticoagulants. So please be careful not to perform ERCP and be on the safe side, and don't hesitate to delay ERCP if needed. Concerning anesthesia, several guidelines and papers showed that for selected patients, tolerability and likelihood of therapeutic success is higher if ERCP is performed with propofol sedation or general anesthesia. So this should be, especially with beginners, this should be really part of success of ERCP. This can be on-site or provided by another ERCP unit as part of a clinical network. So this is something you should consider. So that means that for the practical tips before ERCP, well, you should check for admission and outpatient facilities. If your patient has a complication or a problem, it should be admitted. Check for device availability. Sometimes wonder why we had the device was missing and this was not known before starting the procedure, especially now that we have some shortages of even common devices. So always check with your nurses or assistants that all devices are ready. Check the disinfection process for duodenoscope, that the duodenoscope are ready, and consider using single use duodenoscope for some patients. Always be sure that your assistants are trained for the devices and wire manipulation. Always evaluate the case difficulty and the risk factors associated. And of course, you have to consider EOS access now in case of ERCP failure. And this is better done during the same sedation than to reschedule the patient, of course. Now, to introduce Enrique lecture, I thought on some practical tips for ERCP also. The first one, and this is what I see with young fellows, sometimes, most of the time, they really want to cannulate as quick as possible. Well, I always take 2 to 5 minutes to check for the best position. So this is really an important point. So deflate the stomach, don't overinflate, place your scope, check if the short position is better, check that you don't need to use a long position to have a more tangential approach for the biliary duct. So clearly, this is crucial. It's speed in this time may lead to repetitive pancreatic cannulation and increasing the risk for pancreatitis. Always check that you are not going to cannulate the minor papilla. I see that many times patients referred for failures, and it's, well, the attempts were through the minor papilla, even sometimes by experienced endoscopies. It's always better to cannulate with a sphincter tome. My preference is to use a smaller, thinner sphincter tome, more supple, not too rigid, so that you can really manipulate the direction of the tip of the sphincter tome. And even sometimes I use small tomes. You see the 3-4 French with a O2020 for very small papilla. So sometimes you may use these tomes, but of course you need a good fluoroscopy to have a good vision of these small wires. I use a short system, and I think the short systems, meaning short wires, meaning that you can manipulate the wire yourself. And this in my practice was very, very helpful, because it means that you manipulate your scope, but your scope, you manipulate it with your body. You can manipulate the sphincter tome, length of extension of the sphincter tome in the duodenum, and you manipulate the wire yourself. And then you need your assistant, of course. The assistant is very important because the assistant will bend the sphincter tome to the appropriate direction, and Enrique has videos on this. And also the assistant can inject. And I think this is what I like to use and what I like to teach fellows. It's to combine small injection with wire manipulation. And this usually opens the papilla and gives you a small information. You don't have to inject cc's, just small amount, to show the beginning of the duct and to see the shape of the beginning of the duct, so that you can then manipulate your scope and your sphincter tube to enter the bile duct. And the last tip is, if PD cannulation is repetitive and unavoidable, please go for a pancreatic stent. Do a pancreatic sphincterotomy in the bile duct direction. Place your stent, retrieve your sphincter tome, and reposition then your wire into the biliary direction. Once the stent is in place, it will straighten the bile duct, and it will make the cannulation of the bile duct much easier. And I think what I see in my lawsuits is several attempts of the pancreatic cannulation, and then the endoscopies, they go away of the pancreatic duct, but you should take the advantage of being in there, placing a stent, straightening the sphincter, and go then after the stent placement to the biliary. And then you have your prophylactic active stent working, plus the NSAID, plus the lactate. That would mean that you will decrease the rate of pancreatitis in your unit. In my unit, we have 2% pancreatitis, and we had no severe pancreatitis because we use all these steps and we try to be very careful. So please, ERCP is a beautiful procedure, but be careful. Thank you for your attention.
Thank you, Pierre, for this great first presentation and introduction into the topic. We have a lot of questions and we will discuss at the end of the webinar. And now I would like to hand over to Enrique for the practical tips for the cannulation. Enrique, please.
Thank you very much, Marcus, for being here. I'm very happy. So in this second part of the webinar, I will present you some tips and tricks for practical cannulation. As you know, everyone and every interventional endoscopist is following some kind of mental algorithm when he is performing biliary cannulation. And this strategy seems mandatory regardless of the technique we will be using to follow some steps that are crucial or very important. One first sentence I maybe would like to highlight is that to ensure biliary cannulation, the challenge does not really start with passing the guidewire, but with the introduction of the scope. And this is following the recommendation Pierre has been given. So it makes sense to start getting a good position. This is one of the most important parts of having a good cannulation afterwards. It's important to highlight too that too much insufflation should be avoided by passing smoothly the duodenoscope through the gastric cavity. And this is the main reason of having a difficult position in the duodenum, the extension of the gastric cavity. So please take time to have a good position, and afterwards you will have probably an easy access to your bile duct. But a good position for what? Because finally, there are several positions adapted to different indications to perform a sphincterotomy or to perform a biliary cannulation or even to examine the papilla. So there is no one single position optimal for every technique or for every step we would like to do. And at this point, for example, we can see in the left image on the screen a very good view of the infundibulum of one papilla, but probably this will not be the most adapted axis to start biliary cannulation. So this is something that also should be considered. It makes also sense to know that to evaluate the papilla should be done first, and in every case before cannulation attempts. At this point, the central position should be preferred to have a better view of all the papilla area, and afterwards we can also move forward and examine the infundibulum in the next slide to determine the axis. It's important, again, to take your time, and if you have not a better view of the papilla, again, you can also try to improve your position. You can even try to expose the papilla area using your sphincterotomy or using the device you have to ensure afterwards correct biliary cannulation. The axis of the infundibulum should also be considered, and also the presence of a big infundibulum or not, and again, the morphology of the papilla area, because this will also determine not only the primary biliary cannulation technique we will be doing, but also the rescue techniques we can also be proposing after a failure or after a difficult case. But when we are speaking about position, we are not only talking about the position of the duodenoscope, but also the position of the patient. Sometimes this is a good idea to change to lateral position, or to change the position of the patient to ensure a better exposure of the papilla area and again, a better cannulation technique, or the position of the endoscopist. In this slide, for example, you can see both positions for a single endoscopic position in both images. So finally, we can also expect that the body position of the endoscopist can be important to be comfortable and to be using the material and the devices we want to be doing. Finally, and this is maybe one of the points of interest of the presentation, what position should be taken for biliary cannulation? Well, it's true that there is, as always, not a single answer, but I will propose to place the papilla in the right and superior side of the monitor. Afterwards, sometimes the long position can achieve a more infrapapillary orientation, and so we can be closer to the papilla area to start cannulation in long position. But I recommend, if this is technically possible, to start in a short position close to the papilla. Use the control movements up and down, and we will see some videos with a big wheel to move the endoscope toward and away from the papilla. It's also a very good exercise we need to understand and technically to use, not only to start the cannulation, but afterwards, as we will see, to manage and to move the sphincterotomy and orientate the axis we would like to be passing the guidewire to perform deep cannulation. Overall, as this also have been discussed, wire guide cannulation should be preferred. Here you can see different images of the major papilla. One can expect that finally, and this will be my advice, the shorter position and closer to the papilla is usually a very good idea and a good starting point, as we can see in the middle image of the screen. So at this point, maybe you will have a control of where you are placing your sphincterotomy in the biliary orifice. You can examine the papilla again, even if you have already been doing this before. And afterwards, once you have your sphincterotomy into the biliary orifice or into the papillary orifice, you should try to keep your tip of the sphincterotomy on this area and not to lose the sphincterotomy and start and restart again and again. Because more you are performing touches of the papilla, more the risk, as Pierre has described, of pancreatitis or other complications can come. And also, you will never know what you know. You will not be sure if this was the correct place or not. So finally, I will be advising you to start in the biliary orifice and afterwards to change your axis from left to right or to up to down to be sure that this is the correct place. And again, if there is some stenosis or biliary stones, or depending on the indications, you should adapt your technique. So overall, it's better, and I think this will be more comfortable to start in a closer position rather than, as in the left image, a long position far away from the papilla area. Here we can also evaluate the axis to understand the vertical axis of the sphincterotomy we will be using during the cannulation. And at this point, we have several primary cannulation techniques that has been already described. Overall, the technique we are proposing, and this is one of the most common ones, is to use the sphincterotomy, advance the tip of the sphincterotomy to 5 millimeters into the biliary orifice, and afterwards we start guidewire passings. Sometimes you can also use the no-touch technique in small papillas, and also the direct access can be an option, mostly in experienced endoscopists for standard papillas. Some skills are also important, for sure. And so this is one example of controlling the left movements with your small wheel in order to have the axis of the infundibulum ready to be the same as the sphincterotomy. And afterwards, before trying to pass your guidewire, even if everyone has this this way of doing, sometimes I am expecting to pass my guidewire very quickly, but sometimes it's better to bend the sphincterotomy in order to have the correct axis in the vertical side before starting the passing of the guidewire. And at this time, if you are doing in this sense, maybe you will be avoiding pancreatic duct cannulations. In the same way, we can also control the horizontal axis when we are performing cannulation with movements either of the small wheel of the endoscope, or, as this is my preference, with the left hand of the scope. As you can see in the image and the video on the left, you can control, if you are in short position and with a good position, very, very well, your sphincterotomy from the left to the right and right to the left, in order to try again and again with your guidewire yourself or your assistant, and to have and to achieve your deep biliary cannulation without keeping out with your sphincterotomy from the papilla area. So this right to left movement to change your horizontal axis should be combined with the vertical axis movements we have done using the banding, mostly with your assistant or with your nurse. And at this point, you will achieve the correct axis following the infundibulum and following also each particular anatomy in the papilla area for biliary cannulation. It's also important to understand and correctly place the fluoroscopy. Sometimes we are expecting to have a direct biliary cannulation, and so you use the fluoroscopy and we have an image of nothing because, well, this is not correctly placed before the examination. So special attention should be paid to have a good fluoroscopy, well placed, with, if this is possible, not oral materials into the monitor that can misunderstand or can make problems interpreting the images we will be seeing, as in this image, that this is for more cholangiogram in a deep biliary cannulation, but we cannot know if this is a stone or this is really a stenosis or there is nothing there because we have not a good view with the fluoroscopy. So this is also an important point. And afterwards, you have to keep in mind, I think everyone is aware of the material they are using for. Everyone, as I have said at the beginning of the talk, has his mental algorithm following the sphincterotomy and guidewires they are being used in their local expertise and areas. But this is even more than important. This is crucial because if you are in primary biliary cannulation and you have some difficulties, one of the second step or rescue therapy before going to very advanced techniques you will have is to use different hydrophilic guidewires or more adapted sphincterotomes and so on. At this time, I prefer and I like the sphincterotomes sometimes with a short cutting wire because I am used to work very close to the papilla area, and so these sphincterotomes can be more adapted in this setting. But finally, there are a lot of different devices we can be using, and what is important is to be aware of the material we will be using in case by case. We have already been discussing about communication skills in the first presentation. I will maybe add that communication skills are also important, as has been already presented, with all the whole team in the operating room. This is something sometimes is not very highlighted in most of presentations regarding this topic. From my side, to have a good communication with the nurse, with the assistants and everyone in the room will ensure that biliary cannulation or the whole procedure is probably done correctly and properly. So this is something I will advise you. It's important everyone in the room to be aware what we are doing, what we will be using, anticipate the devices we will probably be using for, and so on. And at this point, you will probably have success quicker than if you are alone from your side. And I think this will be all from my.
So thank you, Enrique. Thank you, Pierre, for these two very brilliant presentations. Enrique, you were very quick. I thought you have some more minutes. So nevertheless, we have a lot of questions there from the audience. May I start with Pierre? There were some questions regarding the non-steroidal anti-inflammatory drugs in the ERCP to prevent post-ERCP pancreatitis. And you clearly showed us that direct administration should be used in every ERCP without contraindications. So there is a question, what about the level of the creatinine? Do you have a cutoff where you will not use the drugs?
Well, there is an international cutoff of 30 mils filtration, glomerular filtration. So that's the cutoff where NSAIDs should really be avoided. Between 30 and 59, you should not use prolonged use of NSAIDs. So that means as a single administration of NSAID, I think is of less importance. And I wanted to make the point that you can always find a reason not to administer NSAIDs. It's a repeat ERCP we had already before, and there was a question also on a repeat ERCP for extraction of sometimes big stones. Well, I've seen pancreatitis at the second ERCP because sometimes the procedure can be long, the stone can be impacted in the ampullary region. So it's better to be systematic and to really not administer if there is a real contraindication, because otherwise there are always discussion, or this patient is not at a real risk. And then you have a complicated procedure and it's too late, because we know that if you administered it during the procedure or after the procedure, it will be less effective. So I like to convince my team, my nurses and my assistants to give it systematically, except when there is a real contraindication. And the real contraindication for renal insufficiency is less than 30 mils glomerular filtration.
Mm-hmm. And what about if you already give the rectal administration before the procedure, and then you pass the pancreatic duct one time, second time, and then you should place a prophylactic stent, and then you do both, or the rectal administration and the stent?
Yes. Well, again, you have to calculate the risk. The risk is easy to calculate. You just combine the different risk. If it's a young woman with SOD and you have been several times in the pancreatic duct, I would put a pancreatic stent plus the NSAID plus the lactate pharyngase solution. Not maybe a high volume, but normal volume. So you have to be on the safe side, because I think the risks are limited. But of course, if you want to place a pancreatic stent because you had a difficult procedure and it took a long time, but you have problems then to re-enter the pancreatic duct, then I would not spend 15 minutes more to try to place a pancreatic stent. But if you are in the duct, and this has been done repetitively, it will help biliary cannulation. This has been shown in many studies, and really it can be very helpful. Short, 5 or 4 French stents, of course, and or a stent that will be expelled because it has no flanges. Those stents are easy to place.
Okay, great. So one question to Enrique. You showed us very interesting practical tips how to move the scope, how to handle the sphincterotomy and all the other stuff. The question is, how long would you deal with a papilla? So for you as an expert, do you spend 5 minutes, 10 minutes, or more before you go to an alternative technique?
Yeah, well, this is a very, very interesting question. It's true that in real practice, I will say that there are a lot of factors who will be impacting this decision, because finally, it's true that in the guidelines we can consider that an ERCP is difficult very quickly in terms of time, when we are spending more than 5 minutes or more than 5 to 10 minutes. But in my practice, I try to achieve retrograde cannulation every time I can with primary cannulation techniques. Afterwards, for sure, I try to stop my first technique and to move forward to other techniques very, very quickly. This is also depending in the problem I have. If the problem is deep cannulation, because sometimes we are already in the biliary orifice, maybe I will spend more time in these patients, because I understand that I am already in the biliary duct, and so the risk sometimes of pancreatitis will be lower. And at this moment, we are leading with stenosis or strictures or angulation due to the morphology of the papilla. If I have no access at all, and particularly in papillas with tumoral invasion, at this moment I will be moving very quickly to other techniques, like, for example, US biliary drainage. Another point will be if I have an access to the pancreas or not. If I have an access to the pancreatic duct, I will be probably moving very quickly to double guidewire technique or pancreatic pre-cut.
Okay, that means it depends if you are not able to cannulate the papilla itself, or if you are in the papilla and then you have problem to go to the duct directly. Yeah. Okay, very clear. Pierre, one question. You clearly showed us the risk factors, how the patients develop complications in ERCP, bleeding, perforation, post-ERCP pancreatitis, and so on. What about if you have a patient who already had a complication, like a post-ERCP pancreatitis in the past, and then he has to undergo a new ERCP? for several reasons. So how do you deal with these patients? Do you change your procedure, how you do perform an ERCP, or what would you recommend?
Well, it really depends on the on what happened during the first ERCP, and if it's just exchange of stent or recurrence of stones, or it depends on the indication. Well, patients who had a severe pancreatitis, they fear the ERCP procedure, of course. So sometimes you have to convince them that it may help them to repeat. What I know it's a topic you like a lot. I had some patients with familial polyposis who had pancreatitis after the empilectomy, and they have a recurrence.
Mm-hmm.
So of course, then you have to convince them, and you have, of course, really to be very, very precise on the appropriate indication and the timing. Sometimes we can just wait if it's a small recurrence, and we can wait maybe a couple of months or years. But yeah, you have to rediscuss, and you have to be sure to take all the preventive measures, and of course perform the examination by the most experienced ERCPist available in your unit, or sometimes refer to an expert center, because I think the rate of complication is really related then on expertise, the use of systematic use of preventing measures. A short exam will lead to less complication than a long exam. So experience here is playing a huge role.
Okay.
We have patients with SOD dysfunction where you do a sphincterotomy, they have a pancreatitis. Usually when you take all the preventive measures, it will not be a severe necrotizing pancreatitis, but they may have recurrent pain. So in those patients, repeat ERCP may be useful, because they can have a stricture, or maybe you have to go for pancreatic sphincterotomy added to the biliary sphincterotomy. But of course, this is discussed during the consultation, and really patients there, they have already good information, because they went through the process and they know what can happen.
Okay, perfect. Enrique, if you have a patient with a diverticula in the region of the papilla, or a papilla into the diverticula, how do you deal with that? What are your tips?
Yeah, for sure. There are a lot of tips in this setting. It's true that this is not as unusual as we can guess, because finally all patients are very more risky to have their papilla in a diverticulum. At first sense, I would like to say that it's not very common to have a real intrapapillary intradiverticulum papilla. In most of the cases, the papilla is in the side of the diverticulum. So again, it's very important to check the wall diverticulum, sometimes to take time because there is some food inside, and so to have again a good examination of the wall area, because at the beginning we can expect not to see the papilla directly, and so we pass sometimes. It's important also to understand that sometimes these patients will have several diverticula, and so the papilla is not in this one but in the other one farther away, or the diverticula is deforming somehow the anatomy. So sometimes should be spent in this sense. And afterwards, when we have seen the papilla, it's very common to have a far away position and to be like far away from the papilla area, and it's sometimes difficult to get closer, needing the long position of the scope. So in my practice, sometimes I am using long cutting wire sphincterotomes, 30 millimeters, because sometimes this is like straighter and allows me to perform cannulation easier. Sometimes I am also using straight catheters, because when we are far away from the papilla in a diverticulum, it's quite difficult to use a short cutting wire sphincterotom who is going up very quickly, and so you are not achieving the biliary orifice. So I use straight catheters, and if this is not working, I try to go inside the diverticulum with the scope in a long position to have the closer position to the diverticula, and again to have the catheterism, because in most of cases the issue is not really the difficulty of the papilla, it's the difficulty of the position and on the axis. But once you have a good axis, the guidewire is usually passing nicely.
Okay, great. Great. Another question regarding such a topic. What about if the patient is not in a perfect position? If you have to do the ERCP in supine position?
May I just answer about the diverticulum?
Yeah, of course.
So there are other tricks, of course. We published 20 years ago the rendezvous technique, which is sometimes interesting in those cases where you puncture the pancreatic duct with the US scope and then you push the wire. Usually there is no stricture and the wire comes out and you can then cannulate. I like also a technique when you have your duodenoscope, you use a small forceps, pediatric forceps, and you pull the ampulla and then with a small catheter, with a small wire, you push it in the papilla, and that's my preferred way to work. Some other people use clips to change the position of the papilla. So there are many different techniques to access the bile duct. And sometimes we use a gastroscope to get into the diverticulum, but that's, yeah, there are some limitations. I think rendezvous then is better than all those complicated techniques.
Yeah, but if you use a forceps and a catheter, then you put both to the same working channel, or?
Yeah, but you have to use pediatric ones. So pediatric forceps and a small catheter for 0.20 or 0.25 wire.
Okay.
These are pediatric devices. We have a pediatric, we have children where we perform ERCP, so we have some devices for children.
Okay. So there is another question regarding the perfect position for ERCP. What if you have to do the ERCP in supine position? Are there any tricks? Because there's something different, like the position of the papilla and so on?
Well, it's true that the position, the perfect position will be depending if the difficulty is to pass the pylorus or the difficulty is to achieve a close position to the papilla, or if the final end is to understand the ileum anatomy, because sometimes in the fluoroscopy, for examining the region of the ileum, will be maybe easier to have one position of the patient than other. So we should expect also to combine several different positions during the same procedure, and not to choose only one from the beginning to the end. This is maybe one of the points I will point out. And afterwards, for sure, this is also a question of local practice. So the position of the body of the endoscopist is not exactly the same when we are performing endoscopy, biliary cannulation in lateral position compared to the cubitus position or other. But well, I will say that this is more a question of local practice. I don't know what you have. What do you think, Pierre, about?
Well, you know, I like the prone position. The prone position. I think it's a very stable position in case of bleeding, or when you have no bile around your scope, you have no blood if there is a bleeding. So, for example, an ampuloma resection, I would never do that supine. Prone, you are very stable. I see that during the workshops I participate, most experts, they like to have the patients in the prone position, because if there is a problem, it will be easier to manage bleeding or to have a good view of the papilla and diverticulum. Of course, the left lateral is easier, but then you have the problem with the fluoroscopy, and sometimes you may have problems to, especially when you want to go for intrahepatic biliary disease. So that's my preferred. But of course, you need an anesthetist to agree with that. Now with the COVID pandemic, they like more the prone position for so this has changed some anesthesiologist's opinion about that.
I understand. Here, another question for you. Can you describe the siphon technique for biliary cannulation?
The what?
Siphon, S-I-P-H-O-N. I'm not sure.
No, I don't know.
Later, Enrique?
SIP.
This is a question from Dr. Stefanidis. Yeah.
Well, I think the problem, I don't know if it deals with this, but it's the S shape of the bile duct. So that means if you have a bile duct with a real sigmoid shape and a siphon on the bottom of the bile duct, then it's this has been well described into atlases from Michel Kremer and Jacques de Vière, when it really explains you how to enter the first 3 millimeter of the bile duct, and then to go up and pull the scope to advance then the sphincterotomy to get into the S shape. And then finally, you push your sphincterotomy above. So that's a three-step changes of movement, up, down, and then up again. So that's a technique that you have to use when you have a really S shape of the bile duct. And then sometimes if you always go into the pancreatic duct, placing a pancreatic stent may avoid this problem. And sometimes it's very easy then to push a wire when you have such a problem, anatomical problem.
Okay, very interesting. To be honest, never heard this before. Okay, so very short question, maybe to Enrique. Is there an age limit for ERCP, 90 or so on, or I don't think so?
Yeah, well, I don't think so either. It's true that the age is always a difficult matter. More than the age, I will say that the most important is the performance of the patient, the family, and also, as we have also been discussing, if the anesthesiologist is in agreement with the procedure or not. So there are a lot of factors to consider, but I will not say that the age itself completely alone, this is a limiting factor for ERCP.
Okay, completely agree. Pierre, there is another question for the prevention of PEP. What hydration fluid would you recommend? Does it make a difference?
Well, there is data with the lactate ringer solutions. We have no lactate ringer, but we use Hartmann, which is very similar. I think it's better than to use just saline. I think there is some proof in the literature that that it's effective and that it should be used if you are not using NSAIDs or pancreatic stents.
Okay. And another question is, in this regard, do you have experiences with ketoprofen as rectal administration?
No. Sometimes we only give intravenous NSAIDs because the anesthesiologists, they use it. Some of them, they use it systematically for their general anesthesia. So of course, if they have already given an NSAIDs for the anesthesia, then we don't give rectal NSAIDs. I think we should keep on the NSAIDs that have been studied and that are proposed by the guidelines, ESG guidelines and other guidelines, rather than changing the type of NSAID. So I don't know if COX-2 are efficient, and I don't think there will be more studies about this topic.
So there is another question regarding the passes of the guidewire to the pancreatic duct. Maybe Enrique, I think we all agree that after the second pass of the pancreatic duct, we should place a stent, not necessary in the first one, or?
Yeah, sure. Well, I think that at this moment we have a lot of evidence-based data analyzing, even in the randomized fashion, that patients who undergo repeated pancreatic duct cannulation have finally a less successful biliary cannulation compared to double guidewire cannulation, pre-cut, or other techniques. So maybe the questions will be, after a second pass of the pancreas, we are expected to be performing pancreatic stenting, but what technique should be done afterwards, if double guidewire cannulation or pancreatic pre-cut, or placing the stent and doing biliary cannulation over the pancreatic stent. This is maybe the question regarding, again, local practices.
Okay. And another question for you. Some of the participants, they understand that the success rate is higher if you use a propofol sedation compared to a general anesthesia. I think this was a misunderstanding, or?
That there is a higher rate of biliary cannulation if you are using propofol sedation. I am not aware of well-designed trials comparing both. I don't think, at least in my practice, there is a difference. I think deep sedation, well controlled, could be enough for most of our ERCP procedures, and we have a lot of data on this. But in France, and particularly in our center, we are performing most of our cases under general anesthesia. So this is my day-to-day practice.
Yeah, the problem is mainly inhalation of fluids. But this can happen also with general anesthesia. When you take the tube out, patients can inhale at that time. So that's the main problem with deep sedation compared to conscious sedation.
Pierre, there's another question regarding lactate ringer solution. If you use it, at what dose do you use? 1 liter, 2 liter, or how many do you use?
Well, I think the most recent data show that high volumes are not of interest. So we use the classical perfusion. Usually it's 1 liter during the procedure and in the recovery room. And then we continue in the ward if the patient is admitted. But high volume is should not be used, I think.
Yeah, we agree.
Yeah. So there are two questions. They maybe are a little bit out of the topic, but I think they are also interesting. Enrique, if you try to use cannulation of the minor papilla, do you have any tips how to perform this?
Well, this regard, for sure, Pierre has much more tips than me, but for minor papilla, the position is slightly different compared to biliary cannulation of the major papilla. So sometimes you are expected to be either in a very, very short position while expecting, like while you are performing the introduction of the scope, to check the minor papilla, and at this time to try cannulation, but this is not very stable, or to have like semi-longer position. The position is not exactly the same. I will advise to use dedicated sphincterotomes. This is very important. Because we know if not very, very quickly, you can have a lot of inflammation, and that can become very, very difficult. To be sure that this is minor papilla, again, as Pierre has also described. And I know that there is also the use of secretin that can be useful to identify the orifice and to open the orifice, ensuring that pancreatic cannulation is done. But we have not the experience in secretin use here in Paris. I know Pierre has a lot of experience on this.
Yeah, I think if you don't see the orifice precisely, then it's much easier with secretin, because you, except maybe in a very severe chronic pancreatitis with stones everywhere. But otherwise, for young patients with recurrent pancreatitis, if you don't see the orifice, usually we use a semi-long position to be on the appropriate position. Secretin will open the orifice, and also you will see fluid coming out. And at that time, if you push the wire, hydrophilic thin wire, O20 or O25, it will just go directly into the main pancreatic duct. And in those patients, usually during secreting infusion, I try not to pacify, and I'm very happy once the wire is in place to do a short sphincterotomy, stand, and that's it. Because we had MRCP, or we had other imaging techniques, and so we don't need to re-opacify those ducts, especially in patients with recurrent pancreatitis, who are young patients or female or high-risk patients.
Maybe another tip will be also to use like the no-touch technique to take over the guidewire, and to try to cannulate using the guidewire as an introductor, because sometimes you are avoiding passing again with the tip of the sphincterotome that can be much more aggressive. So
yeah, for sure, it's always with the tip of the wire, and you need a very good assistant. The chances to succeed is also linked to the assistant, because it's moving. So the assistant has to push the wire at the appropriate time when the orifice opens up. we have a good nurse who is always successful in this, Sebali. She's very, very quick on pushing the wire when it's needed. So assistant is of importance, great importance also.
Great, great. Pierre, there's another question for you. Can you comment about transpancreatic septotomy?
Transpancreatic?
Septotomy.
Ah, yes. Well, I've been doing this for more than 20 years, and I think if I repetitively cannulate the pancreas, which I try to avoid, but if this has been done before I start the procedure when a fellow has started first, I like to do this. In fact, I put the sphincter tome in the direction of the bile duct, 11 o'clock, and I use pure cut. I try to avoid and to use coagulation currents. So it's either endocut effect 1 or just pure cut to avoid any coagulation on the pancreatic entrance. And then I go to the 11 o'clock. I pull my scope so that I'm really cutting the sphincter into the bile duct direction. And sometimes you see bile coming out at that step. So then you have either to take the decision to put a pancreatic stent, which will make it easier, in fact, or you don't place the stent if you think you can succeed. And most of the time you can get access to the bile duct. So I think it's a very easy procedure. And in fact, in my experience, I never use pre-cut, except really occasionally. The transseptal technique is usually very easy. It's quite a stable technique. The risks are minimal, except if you are in the minor papilla, because if you do this in the minor papilla, you perforate, of course. But most of the time, it's a low-risk procedure. But there is a risk of acute pancreatitis, so be careful on all the preventive measures again.
But only to clarify, it's the same as a transpancreatic sphincterotomy. It's the same procedure. Yes.
Yeah.
Okay. So we did not talk about fistulotomy on this evening. Do you perform this in case of difficult biliary cannulation, Enrique?
Well, I have been training in Brussels, so I don't perform a lot of biliary pre-cuts. Now in my practice, I am moving forward to use biliary drainage when I am in travels and I don't have a biliary access with all the standard techniques and second line, I would say, techniques. If I have the pancreas, we have already been discussing about it, I try guidewire, double guidewire technique or pancreatic pre-cut. With this, in most of the cases, I can have the access. The situation I will be doing pre-cut, standard pre-cut by infundibulotomy even very quickly, even the early pre-cut, is in a very, very big papilla with a big stone of 30 millimeters, very, very evident, very nicely. At this moment, why not? This is not very risky. And so even I don't try a lot by retrograde way, but this is not so common. So this is the only setting I will be doing in my practice, even if this is also discussed and recommended in some guidelines or papers in the literature, the early pre-cut, but this is not my personal practice.
Yeah. So maybe a last question to Pierre, because we're running a little bit out of the time. If you decide to do a US ERCP rendezvous in the case of difficult cannulation, do you have some recommendations what type of needle and guide wire we should use?
For US, you mean US
ERCP?
Well, it really depends on the if you have a malignant, you mean a malignant obstruction failure of ERCP. When there are different techniques you can use. You can put lamps, perform a CDS, or you can go transgastric and transhepatic. Yesterday we had a case where we had gastric outlet obstruction and obstruction of bile duct. So we performed first gastrojejunostomy, and then we had no access to the common bile duct, so we did transgastric introduction of we used either the well, there's several 19 gauge needle available. There are advantages of each of them. And then you push a wire, and we were lucky that we were able to push the wire through this tumor into the duodenum, and we performed anterograde metal stent for this patient. And in this case, I left a small pancreatic stent through the hepatogastrostomy in case of need for revision of the metal stents. But usually we only do anterograde or hepatogastrostomy. But there are many other techniques. You can try rendezvous. There are many things you can do, many needles, many wires. We are not going to speak about different companies. Each of them has some advantages.
Yeah, this is maybe a topic for one of the next webinars. So, so we are 5 minutes after 8, and I think this was a great webinar. We had a very intensive discussion of about 30 minutes, and I hope we answered almost all questions. So I would like to thank all the participants for being here with us. We had more than 300 participants. I'd like to thank all of them. And we have some announcements of the ES3E. And maybe you see this, we all are the face of the ES3 of the endoscopy. And of course, it's necessary to become member of the ES3 and to renew the membership. Don't forget this every year, please. And the next slide. And for the upcoming ESG days in next year in Berlin, in Germany, then we have the new ESG reset grant, and the application is open. Please take the time and take the chance to apply for this grant until November the 15th. And also you can register then for the next ESG days in Berlin. And of course, you can submit your abstracts, and the abstract submission open soon. It starts from November 23rd on, and then you can submit and register for this congress. And our next webinar, this is next week, and we have another very important topic with the endoscopic full thickness resection, and this is presented by Maria Pellis and Arthur Smith and Barbara Bastiansen. And I think this will be also a very interesting webinar. And I thank you again for your time and for your participation, and hope you had a very nice evening. Thank you.